Thank you very much, Jody, and good afternoon, everybody. We appreciate you being here today. And today is day 731, which is 2 times 365 plus 1, which means it's the second anniversary of the first day we were identified new COVID cases here in the state of New Mexico. Let's go to the next slide. The case counts, hospitalizations, and deaths are shown here, again, with a very steep decline. We're very happy to find out that we're now at a level we were before we entered the Delta wave in August, or right as we were entering it. And so that's good news. And our case counts have dropped by more than 50% just in the past 7 days alone. Total hospitalizations, you can see there, but with another significant drop, only 107 new admissions, only 150, 160 people in the hospital today. And so that's also very, very good news. And then lastly, we're up now to a total of 7,050 deaths here in New Mexico. Again, over the last 14 days, a little higher. It's hard to compare 14-day periods at a time like this with the drop-off in cases, because there is a 6-week backlog in death reporting to the date. We feel like the data is relatively complete. So we'll continue to see that gray area on the chart fill in, but COVID still remains a serious disease. Next slide, please. I just mentioned it's the second anniversary. There were 4 new individuals, 4 cases we reported on March 11th. I was just talking to Mike Edwards this morning, who's the director of our lab, our state lab, who was staying up late into the night to confirm the testing on our first 4 cases. And at this time, we'd like to take a couple seconds here to remember the folks in New Mexico and their families who lost their lives. Brianna, can we go to the next slide? We're going to take 70 seconds of silence. That's 1 second for every 100 people who've lost their lives here in New Mexico. And I would invite you to spend the 70 seconds, which will seem longer than 70 seconds probably, but spend this time with us reflecting on people we've known and lost, or friends who've lost loved ones, husbands, wives, children, parents, other family members. Let's just pause in remembrance on this 2-year anniversary of the pandemic for these and remembering our fellow New Mexicans who've lost their lives. Thank you. Okay, thank you all for taking that time with us today to remember all these folks. And remember also, these included many healthcare workers, frontline first responders, and others who contracted COVID and lost their lives in their efforts to protect other New Mexicans. Let's go to the next slide, Brianna. And just a quick update on hospitals. This will be the last week we will score this for a while, and unless something changes, our MAT hospital team is going to be looking at this and revising the scoring system a little bit. PPE is no longer an issue. Staffing is a bigger issue, and doing that in the interim. As of today, we're doing well with general medical beds up to 99, almost into triple digits. Still a little tight on ICU beds. Most of these, of course, are not occupied anymore by COVID patients, but other individuals with serious disease, the regular busy season we have in the winter that begins to die down just right about now each year, and also folks who delayed their care and now are in the hospital because of complications from not getting care for their underlying medical issues. We spent a good amount of time at the medical advisory team this morning talking about workforce issues. The state will continue to supply some additional nurses and other technicians and other healthcare workers to support hospitals with occupancy rates over 105%. FEMA has announced their intention to no longer pay for 100% of pandemic-related expenses starting July 1st. And so we at the state are busy on working on that. And I'll say a little bit more about that in just a little bit. I did want to take another moment here to thank the hospital leaders who came together. We took a moment this morning to talk about our, the high points and low points of the last 2 years with COVID. And to a person, everybody on the medical advisory team said, we have built relationships as a result of responding to this pandemic that will never go away. And we want to continue having those relationships as this pandemic ends to tackle some of the more serious and significant issues in the health of New Mexicans as we move forward. So obviously that's a very positive outcome of the pandemic. And we'll talk a little bit at the end about how, despite all the hardships, we still have things to be thankful for. Next slide, please, Brianna. I wanted to show you this graph. To me, it looks really familiar. The height of the curves aren't exactly the same, but this is not COVID-19. This is the great influenza in England in 1918 to 1919. And you notice these, a small wave, a giant wave, a small wave again. And it kind of reminds me that you never know what's going to happen with this virus. I think some of you who've been coming to these for a long time, remember I talked a lot about the great influenza pandemic in the first year of COVID and using that as a pattern. And it's been a good guide, but if you really squint and count up the bars on the x-axis there, you'll see that all 3 waves occurred in less than a year. And here we are now ending our 2nd year of the pandemic. We don't know what's going to happen next. We don't know what to expect for sure, but we are getting ready for that. But it's interesting because I'm pretty sure that on April 5th, 1919, folks around the world seeing the most deaths of any modern infection occurring around the world, seeing that they had no idea on April 5th, 1919, that they were about to come to the end of that serious pandemic. And we don't either, but here's hoping. And I wanted to show that just as a reminder that you don't know that it's over until it's really over. Next slide, please. Just to hit some highlights, we've already talked about our 4 confirmed cases back 2 years ago today. We went through battling a number of smaller kind of surges in the pandemic. And then in October of 2020, a huge surge, one that we were not really able to handle. We, as well as we hoped we had, mainly because of our low baseline supply of hospital beds, and despite the incredible efforts of our delivery system partners. And we did activate the crisis standards of care for the first time on December 9th, 2020. And we talked this morning again with members of the operations team about how most of us went to bed that night thinking that we were not going to have enough resources to care for sick New Mexicans the next morning, and that many, many people would be denied access to ventilators and other life-saving treatments. And for reasons that I still don't completely understand, that night, there was a sudden change in the number of cases and a drop-off began, and we never actually got to the point where we had to do that. I skipped our first death, March 25th, but then going on to December 14th, shortly after the worst point that many of us remember in the pandemic on December 9th, we first started administering vaccines, and many of us remember the joy we experienced either giving vaccines, getting vaccines, or just knowing that vaccines were going to be available. And I think many of the folks who, when asked what their brightest moment was of the pandemic, cited December 14th and finally having those vaccines roll out. And I've told you all in the past, in December of last year, of 2020, the joy that I saw on healthcare workers' faces to finally have an effective tool to combat the vicious virus. Next slide. Spring of 2021, we took a big forward leap. Actually occurred in the winter, but in really prioritizing equitable access to vaccines and specifically reaching out to low-income communities that would have a hard time taking time off work, getting to vaccine sites, et cetera. And we actually transcended the severe inequities in New Mexico to the point now that it doesn't matter what your income is, what kind of level of serious illness you have. Everyone in New Mexico had equal access to the vaccine if they wanted a vaccine. We also kind of won the first leg of the national race at the end of June 2021, with 70% of New Mexicans having gotten their first shot. And that was a great moment as well for New Mexicans. And kudos to former Secretary Tracy Collins and continuing Deputy Secretary Laura Parahone for masterminding an unbelievable rollout of those vaccines with help from every person in the Department of Health. Major help from delivery systems across the state, the National Guard, and frankly, most importantly, all the people of New Mexico who stepped forward to get that vaccine when it became available. You'll remember that in September of the same year last year, we announced the boosters are available for all New Mexicans, followed by the CDC doing the same thing a week later. And we've done well on boosters, although there's still folks who can benefit from getting those boosters. On October 25th, after several long months for hospitals realizing there was no end in sight, the Department of Health declared crisis standards care again, and that continued for almost 5 months. It will expire today at midnight, and we will be out of crisis standards of care in December. Anticipating the change in testing, we started distributing large volumes of at-home tests to New Mexicans and every community in the state. And that was a great step forward as well. Next slide. And then finally in January, some oral treatments. We were able to get into New Mexico and start treating patients in their homes. You know, you could see your doctor, have a positive test, get a prescription, and just take a pill. And we think that the molnupiravir, Vexilabid, and other medications that will be coming along soon will be our mainstay for treatment. Vexilabid reduces hospitalizations and deaths by 88%. And so if we did have another surge with 7,000 more cases from a new variant, and Paxlovid was just as effective, instead of having 700 plus hospitalizations and overwhelming our system again, we'd only have 80. And we'd be able to handle that very, very easily. So wide distribution to every pharmacy in New Mexico and even into caregivers' offices to have these pills ready for people who are sick is a major part of our strategy going forward. The mask mandate, as you all know, was lifted 3 weeks ago. NMDOH immediately provided a toolkit for immunocompromised populations and for the people who care for them. It's available online. And then today, after 8 very long and difficult months for hospitals, we will be letting that declaration expire after 5 consecutive months tonight at midnight. Next slide. Also last week, and just to make sure everyone's aware, the president came out with a preparedness plan focusing on 4 key goals. One is protecting against and treating COVID-19 more immediately. Second is a better surveillance system to prepare for new variants. New Mexico's had a really good surveillance system for us, and I think the federal government has invested heavily more recently and ramping up that ability to test and sequence viral genomes and very positive tests and identify new variants as they come along. Again, on another angle, a plan to prevent economic and educational shutdowns again. And then fourth is just continuing to lead the effort to vaccinate the entire world and to save lives. And so it's good reading. It's 6 or 7 pages. It's well done. I was pleased because it covered all the things that New Mexico had already put into our preparedness plan, and of course some new things that make more sense on a national level as well. Next slide. Speaking of our preparedness plan, we're basically starting in January, put together at the governor's instructions preparedness plan for New Mexico for dealing with the next wave. Yes, we were still right in the middle of the Omicron wave, but we knew based on our modeling that it would be coming down very soon. We pulled groups together to look at testing, masks, vaccines, treatments, workforce issues, particularly in healthcare, how we provide sheltering for individuals who cannot isolate at home, which we've been doing since the beginning of the pandemic, how we're going to report on COVID data going forward. And I'll have a few things to say about that very shortly. And just communications. What's our plan for communicating with the public? And so we'll be asking our media partners here today to join us in a massive effort to educate the public about oral treatments and the importance of getting tested immediately and treated immediately in the event of a future wave. There's only so much you can do in between crises, but the more we can educate and have those thoughts in people's minds, then when we do start seeing case counts going up, we can do another fairly massive media campaign, as DOH has done for many things like testing and vaccines and treatments to the people of New Mexico. And so these plans are more detailed, obviously, than this, but for testing, for example, we say what's the current state. Well, right now, we have 50% of the testing done by vendors, 43.5% by providers and pharmacies, DOH still doing a little bit of the testing, particularly in our rural offices. Between now and in the future, we anticipate a transition to home testing. We still will recommend strongly PCR testing for symptomatic individuals or symptomatic individuals with a negative home test and persistent symptoms. And then we'll still be doing PCR tests with the Department of Health and local providers in rural areas and standing up testing sites as needed, or continuing home testing with people like Vault, Curative, PMG, some of our contractors for people with symptoms. And then for each of these areas here on the left, the 8 things, we have a surge plan for what are we going to do if all of a sudden we have 5,000 cases. And so we are revising our contracts with vendors to prepare for this. We are developing plans with delivery systems and pharmacies to be able to bring testing, PCR testing back up quickly, as well as increasing local distribution to community sites and human services department customers by mail as well. So this is the beginning of the plan. It is almost complete, but not quite complete. And over the coming couple of months, we'll walk through different aspects of this with a little more detail. So you'll know what we're doing now, but what to expect and our plans to be prepared for another wave of a new variant. And so I wanted you to just have a peek into that and more in the weeks to come. Next slide, please, Brianna. Reporting changes. We've gotten a lot of feedback from reporters about what you want to see, what you need most, what things you find most helpful in your work with customers and your readers and listeners and viewers. And so what we've done is sort of conforming to CDC. We will be moving to a new way of reporting where every day by 2:00 on the epidemiology page website, just above the weekly reports, Brianna, you can point to where the weekly reports start, we'll have a whole new daily section that will update Monday through Friday, except holidays, where we'll give you the number of people currently in the hospital, the number of people on ventilators, the number of deaths for this day and the cumulative number of deaths. This is what it would have looked like had we reported yesterday. And then of secondary importance, and we'll talk about this more probably in the Q&A, I suspect, but the number of cases we've had and how many cases altogether. And then lastly, the number of tests. We're not going to be continuing to report test positivity, but for a simple view, it's not as accurate on a daily basis as it is on a weekly basis. You can look at new cases divided by tests to get a test positivity rate at any given point in time. And so that's what that's going to look like. And we'll be tweaking it a little bit with feedback from everyone. We will have access to more detailed data, but we do have a Department of Health to run and a whole bunch of other issues of the health of New Mexicans. And so we're going to be moving away from very intensive manual press releases that literally took 80 human hours a day to produce to this much more automated system. We are busy right now in this beginning of this lull, connecting all of our information systems. So these websites will will update automatically with a touch of a button each day, and you'll be able to follow the data there. And then on a weekly basis, you can catch up on things like deaths and cases and tests on a county level, I believe. And so that's what's new. We'd like to thank everybody who gave us feedback and contributed to that plan. And we're excited not only to have more automation in the process, but also get back to our other work in the Department of Health. One last question that came up just today and comes up every time now lately is, how accurate is the case count now, given that so many people are testing at home? And I said last week, I think the data is less complete. Certainly, we're not getting people trying to report negative tests to us. There are two different ways online. You can report a positive test. We prefer you report online. You can also call, but the online system is more reliable and available 24/7. And we know for sure that we're going to miss some positive cases. I actually know people who've had a positive test that didn't report it to the Department of Health. I'm not sure why they told the acting Secretary of Health that, but they did. I sort of stared at them intently and said, that would be good to go online and report. But we don't even include those self-reports in the case count. And here's why. We verify every one of these cases. We're still using the CDC case definition. So that numerator, that top number, the number of new cases can be a little low. And then the denominator, the total number of tests, is going to be much, much lower, we believe. And we're okay with that, because at this point, what we've learned is the cases themselves are nowhere near as important as hospitalizations. And that is what the stance that CDC has taken in their new recommendations as well. We're already making that conversion. We're doing the same thing there. And we're also looking at giving you a county level dashboard like the CDC's to reflect some of that. The medical advisory team folks and folks at Presbyterian developed one of those, and it'll take us a week or two, and we'll get that online in a weekly report so you can see how you're doing in your county as well, which is particularly important if you have risk factors or immunosuppressed. You want to take different precautions when you go out, and the CDC has come up with some new guidance for that as well. Next slide. Keeping with our custom of reviewing one epidemiology report a week, and these are going to become even more important for those of you tracking your data, because we're moving most of the weekly reporting to this webpage. I think what I'm going to do, Brianna, just to make this a little easier today, is I'm going to share my screen on this one, and I have to share the correct screen now. So I'm going to share my screen, and can you see the weekly reports here?
We just see your background, David.
That is very strange. Let me try stopping sharing, and let me try that one more time here. How about now?
That looks good.
Good. And so again, right up here at the top, you'll see the daily data, Monday through Friday, not including holidays. And the way you get to here, if you forget, is get to any DOH webpage, click on medical and scientific reports, and then click on epidemiology reports. It gets you here. Today, I wanted to talk about the health and social characteristics report. To me, of all the reports, this is one of the more fascinating ones particularly when you think about COVID over time. And so this is the report from earlier in the week. They come out every Tuesday. You can see total cases in the last 7 days, a little bit choppy here. And I learned something new, by the way, looking through this today that I'm going to share with you. This shows actually the distribution of symptoms since the beginning of the pandemic among people. So, if you have a cough, that was the most common symptom, followed by fatigue and headache. And so obviously people can have more than one symptom. Abdominal pain, pretty unusual. Maybe only 1 in 7 people had that, but it was prominent in kids, so much more common in children, that symptom. And here, this is something fascinating to me that I need to talk about too with my epidemiologist, but look at what happened with the Omicron peak toward the end of Delta. More and more asymptomatic people started getting, more and more healthy people, I apologize. This is the percentage of people with underlying conditions. And you can see that it dropped dramatically during Omicron. So Omicron was not like Alpha and Delta preying on the people with the most underlying conditions and the most vulnerable. It sort of universally tore through the population. A lot more younger people, a lot more kids getting Omicron infections this time through. Now, some of that could have been due to vaccination status, but just interesting that this really reflects more youth of the cases and healthier people. As the Secretary of HSD, my favorite slides relate to socioeconomic status. Some of our early viewers in the first weeks of the pandemic remember that if you lived in a low income census tract, you were 10 times more likely to get COVID than if you lived in a high income census tract. Over the entire pandemic now, we're actually down to 2 to 1 or even less than 1.8 to 1, something like that as well. There's more data by poverty level, case rates. In almost every growth, you see this green line at or near the top, which is the lowest income tract. So again, poverty, a serious risk factor. And in New Mexico, that's a big problem because we have the highest poverty rate in the country. And as of this month, 1,057,175 customers, low-income customers of the Human Services Department, which is precisely 50% of our state's population. I'm going to skip through just a couple. Another one that we paid a lot of attention to and still do is that if you are living in a low-income neighborhood, which implies a low-income person as well, you're more than twice as likely. If you're living in a low-income neighborhood, you're more than twice as likely to be hospitalized as someone in a high-income neighborhood. And I might have screwed up the previous slide and done that backwards, but this is the percent of people in a census tract who are in poverty, which is, basically minimum wage or lower. And so 8.85% of those people hospitalized versus 4.2 in high-income districts, and death rates 2.5 times higher in low-income populations than high. There's some notes in there as well. That's of particular interest to us here in New Mexico, as I mentioned, because of our population. And Brianna, why don't you share your screen again and we'll finish up here. So some takeaway messages, as we continue to learn how to fight the virus and be prepared for a future wave, we need to use the tools we have. Stay up to date on your vaccinations. No, I don't know when the next booster is going to be recommended. Yes, I'm going to try to get it on the first day or second day that the recommendation comes out. Still remember, get tested. You can do that at home if you have symptoms. If you have significant symptoms, you ought to get a PCR test. Immediately seek treatment if you have a positive test. And there are pills now, which make this so much easier than having to have an infusion. And then, of course, continue to wear a mask if you're a healthcare worker or you visit a healthcare facility, if your business requires it, if you're sick. you should wear a mask. And just if it makes you feel more protected. I've talked to a lot of people who say, I really haven't really changed what I've been doing. And again, as we work through the details about how we're going to live with this pandemic in our midst, and as we transition to hopefully in the future what someone will declare as endemic state, we want to make sure we really are careful in being kind to our neighbors, friends, coworkers, as we figure out how to do a safe potluck, for example, or how we're going to relate to each other with respect to masks at work. Okay, I think we have just 2 more slides, Brianna. I mentioned this at the beginning, but we've asked a bunch of our workers, what are some things that you're really thankful for as part of the pandemic? And I asked that in all my meetings with employees in both departments and have them put their answers in the chat. And I've got to say that health, family, and having a job for the people who work in state government are the top 3 answers. And COVID's been devastating. We've lost 7,000 people, more than that now, to this deadly virus. But at the same time, I think many of us have learned new things. Many of us have grown. Many of us have changed. Many of us have learned to appreciate when we get it, that time spent with family. We still had folks at the DOH team today, when we were talking about our high and low points, who haven't been able to see their family for 2 years. Their reservation closed and they weren't in it when it closed. And so they're not able to get back in. We have folks who, have lost family members just as you all have as well. A lot of kudos. And one of the things I said this morning was one of the low and high points for me was at the very beginning of the pandemic, when I saw what was happening in Wuhan, China, when it was very clear it was coming to America and New Mexico, and looking around and realizing I was the only doctor on the cabinet and thinking, how on earth are we going to be able to fight this? And then an immediate response as cases came closer, as the governor really led us, I think, very strongly in pushing us to set up data systems, require daily data, require detailed data that really have made us one of the best, if not the best, data reporting states in the country. And we'll continue to provide that data as we go forward. The CDC releases reports about data from 10 or 14 or 16 states on a quite regular basis, and New Mexico is the vast majority of the time one of those states contributing. So all that work is contributing to the health of the nation and the world. I think, I hope that all of you are thankful for our public health workers, for state officials, for the National Guard, for first responders, police, fire, ambulance, EMT, who have been on the scene to help. I hope you're all thankful for hospitals, who I just absolutely have no idea how they do it. They're facing serious staffing crisis because, frankly, COVID has, we've lost a number of healthcare workers to COVID, and people have just become so worn out from relentless working for years against the pandemic that they've retired from healthcare early or decided to switch jobs. So that will be an ongoing challenge for all of us. But those are, I'm thankful for the team that puts these press conferences together and makes it so easy for me to be able to do this every week. I'm thankful for our media partners who have just been with us all the way, challenging us, making us better, and particularly though, and most importantly, letting New Mexicans know what they need to know to be safe in very, very dangerous times. On this point of thankfulness, I just want to say one more thing. Jody, I'm going longer today, and so we're going to give reporters more time to ask questions. Just want to warn you, they should have at least as much time as I did. But there was a study done by Robert Seligman in 2002. It was an internet-based study, and they had 2,000 people that they randomized. 1,000 people got a positive, upbeat message every day by email, and the intervention group, the upbeat message was the control group. The intervention group was asked to go online and enter in 3 things that had either gone well that day or that they were thankful for that day. And at the end of the week, they did a baseline set of measurements. And at the end of the week, after Group A getting 7 positive messages, and Group B writing down 21 things that had happened that week that went well or that they were grateful for. The intervention group, the people who were thankful, wrote it down, were much happier, statistically significantly happier than the people that just got the message. But the main point of that study was that 6 months later, that same group was still much happier, just taking the time to think about the things that they were really thankful for. Of course, being the scientist that I am, I read that article, unfortunately, 10 years later, and immediately started writing down every day the things I'm thankful for. And so many of the things I write down every day are the folks and the efforts that I've mentioned just now. We do have a brief video, I believe, here. And you know what I think we'll do is let's go to the Q&A, Brianna, and then we can just show this as a trailer at the end of the press conference. Jody.
All right, looking at the queue, we're going to start. I have 3 hands raised thus far. We'll start with Matt Hollingshead, and if you could tell us your media outlet, that would be great. After Matt, we'll go to Julia Goldberg. Matt, you should be able to unmute yourself and ask a question.
Okay. Hey, Dr. Scrace, can you hear me?
Yes, I can, Matt.
Appreciate your time, sir. Again, Rio Rancho Observer. With regard to home testing, entering that point, just wanted to confirm, how will home COVID tests be added to the database, for the testing part, where all that info is. And for those, for example, who maybe live in a rural area, don't have internet access to report home test results online, how would they be able to, send their results in? Is there like a specific number to call or other ways they can do that? Or
Yeah, those are both great questions, and I'll answer them both. We will not be reporting self-reported tests in our official case counts because that's not part of the CDC definition. But I have asked our epidemiologists to work on a relatively automated way to collate the self-reported tests and report them separately. And I'm not sure yet if that'll be daily or weekly, but I think we'll do that. Also, interestingly, I was talking to a CEO of one of our state's insurance companies, health plans, last weekend, and they pointed out to me that apart from all these free tests that were sent out, once we get to a new steady state, that their insurance data shows how many tests were run in a lab and how many tests they reimbursed for people who went to the pharmacy and bought them. So that won't be a complete variable, but for example, let's say we found out that 20% of all the tests that they paid for were home tests. We could come up with a way of understanding the PCR test data, rounding it up by 25%. I can explain the math at another time why I said 25 to give us a better idea. But again, if we had 200 cases and 200 people in the hospital, that would be much, much worse at this point than 2,000 cases and 10 people in the hospital. So we really are switching over. And then we do have a call center. And if somebody could put that number in the chat, that would be great. It's not open 24/7, but we are working to make sure people have a way to call in if they don't have access to the internet. And that's why, so we can get some record. But for CDC reporting, until they change and allow us to include those home tests in the results, we won't be including them in our official reporting because the CDC we want to make sure the data we're reporting is the same as the CDC's. And I'm hoping to have a little box, at least in a weekly report, that shows how many people self-reported home tests. Thank you. Great question. Appreciate it.
All right, next we'll go to Julia Goldberg, and after Julia, we'll go to Austin Fisher. Julia, you should be able to unmute yourself and ask your question.
Thank you, Jody, and maybe you'll indulge me. I don't think I can pretend this is one question. So Dr. Grace, just so I can be clear, it appears to me and others that the CDC's new system is entirely based on county level data at the exact point that the state health department is de-emphasizing county level data. So I'm a little bit confused by that, particularly given that the schools now can make their own decisions based on what's happening in their county. And I'm also confused by, last week you said the health department endorsed the CDC, but also that you weren't sure what methodology they were using for determining the colors. I went through all the data and ran some things by you where it did not seem as though counties were being engaged entirely on hospitalizations, because like Santa Fe County, for example, was fine in the hospital categories, but was bad in the case category and was red last week and is green this week. So I guess what I'm trying to ask is, given that there are still plenty of people that want to abide by what the CDC is telling them to do on a county level, how is it helpful if the state is no longer providing county level data? And you did just mention something about a dashboard, but it wasn't entirely clear to me when or how. And then my second question, sorry, is I was unaware until very recently that also the state, you're not going to be reporting deaths by county or demographics of the people who have died, but that is still information you're going to be keeping that we could find through public records, but why are you not reporting it? So is that coherent enough? That was about 10.
Yeah, no, those are good questions, Julie. And, you know, after the press conference last week, I think a couple of days later, the CDC did release a technical document that explained the numerators and denominators and the like. And so we'll have that. We will be releasing county data on a weekly basis still. And so, and no one should be making decisions. I got to tell you that I don't think there's a single decision I made in 2 years based on 1 day's worth of data. And that's why you've been seeing rolling 7-day averages and, you know, things like that to give us a much better understanding of trends. Because, you know, you will see a big peak like this, but then if you look at the detailed data, it's going up and down like this. And so it's only by combining data in a week that we'll do that. So I think that's, I know most of us get dressed based on today's weather, but for COVID and for a pandemic, that data will be more stable if we do it on a weekly basis. We hope. We've also talked about 2 weeks, but there will be soon a county report that translates the CDC data into, you know, green, yellow, or orange for the counties per the CDC guidelines. And that's that little calculator that the MAT and the folks at Presbyterian have developed. They're going to give that to us, and we're going to use that to drive an engine that'll just recolor that map someday every week, in all likelihood Tuesday, but we do everything on Tuesday now, so we may spread some things out in that way. So I don't think we're moving away from data by county. We're just sort of taking a position, as the CDC does as well, that you need to look at this data over time, not on a day-to-day basis. And then by deaths by county, we'll still be reporting those. We just won't be reporting them daily. And so that, again, will be a weekly summation in the weekly mortality report. And I've asked the team, if you look at the mortality report, there is a map with deaths and death rates and the like. We can easily break out the newly added deaths over the course of a week. With deaths, though, it's like a 6-week period before you really know what's happening. So I feel pretty good, like I understand how many people lost their lives to COVID at the end of January, but much past that, we know that data will continue to come in. So we're not, I don't think, I think the CDC is moving to weekly county data. DOH is moving to weekly county data. DOH is moving to reporting deaths and a lot of the other details on a weekly basis. And then there's one last little reason that that's important. Very early on, I wouldn't even say the county because I don't want to make the same mistake again. We had a person die in a very small county that only had one hospital, and they died of COVID, and we reported in the data, you know, in a county that small, someone dies, you know, 2 to 5 times a year, but not every day. And so we basically revealed to everyone in New Mexico or the world, and so it was online, that if you knew who had died in that county, you knew who that person was. And so we have sort of a rule of small numbers. We try not to report numbers in places where there's more than a 10% chance that you could figure out who the person was. So I know we made a slight change to that a while ago, but we're just enforcing that. But I don't think it'll be necessary for you to IPRA stuff to get what you're looking for. And we'd be happy to work with you if you have more specific ideas. It's just, we're not doing the age and county by day. We will provide more data by week. And those mortality reports have number of people who've died by age and gender and the like as well. Thanks, Julia.
All right, next we'll go to Austin Fisher. After Austin Fisher, we'll go to Chris McKee with KRQE News. Austin, you should be able to unmute yourself and ask your question. And could you remind us of your media outlet, please?
Thank you, Jody. Yes, this is Austin Fisher with Source New Mexico. I submitted this question yesterday. I wanted to get Dr. Grace's response to the findings of a National Institutes of Health study yesterday that found that during the Delta wave, school districts with optional masking had approximately 3.6 times the rate of in-school COVID-19 cases when compared to schools with mandatory masking. The data also show that mandatory masking was associated with a 72% reduction in in-school COVID-19 cases compared to districts with optional masking. So I'm curious how Dr. Grace reconciles these findings with the Department of Health's policy choice to not mandate masking in New Mexico schools.
Well, while we try to use all the science we can for every decision, of course, Austin, there are other factors. And I think some of those other factors come into play. A couple things. I didn't see the question you sent yesterday. I'm sorry for that. My team hadn't received anything. So maybe there was an email address error. We just missed it. So I apologize for that. There was a CDC study that came out comparing optional masking versus mandatory masking with similar results. The DOH position is that masks work. We encourage people to wear them. We particularly still encourage people to wear them indoors. I think the CDC guidance when you have more than a certain number of hospitalizations or a certain percent of hospital beds full, strongly recommends that as well. And we always strongly recommend everything that science guides us, but we also hear loud and clear from people who don't believe it's our role in government to tell people what to do, particularly in what you might call a time of peace like we're having right now, where case counts aren't high, hospitals have room for individual people. So what I would say is science, we try to make science-based recommendations wherever we possibly can. We turn those science-based recommendations into mandates when we had no tools that were effective in fighting COVID other than just staying at home and not getting sick. But now with vaccines, with monoclonal antibodies, with IV treatments, with better masking, we're in a position where we're relying basically on good judgment among New Mexicans, school board members, and the like to also weigh that evidence. The New Mexico Public Education Department is the one who puts out the guidance for schools. They work closely with us on that, but it's their recommendations. And I think the governor's decision on this, understanding the evidence and knowing that masks work, was to let communities take more responsibility for those decisions. And I think we're looking to try to do that as much as we can in almost every area, with the possible exception being the importance of masking and vaccination, for that matter, among healthcare workers and in healthcare facilities. And we just talked about that at length at the medical advisory team today too. And if you look at that Delta wave, we went from 800 cases a day to 7,000 cases a day in less than 3 weeks. And so we think it's important that our healthcare uh, our healthcare workforce and our hospital and nursing home facilities be in a constant state of readiness should a next event occur. So I guess that's how I would dissect that all out. And the short answer is that science doesn't, or should it, always translate into mandates, but it can always inform every citizen, every community, every school district to make wise decisions. Thank you.
All right, next we're going to go to Chris McKee from KRQE News, and after Chris, we'll go to Jared Epidemiology. Chris, you should be able to unmute yourself and ask your question.
All right. Thank you very much. Thank you for the time. Good to see y'all. I had a question in relation to, Dr. Scracy mentioned just even the man hours that went into the daily data reporting. This is sort of a new phase of work for the DOH staff. Obviously, I think in the past we've talked a little bit about how the DOH added a ton of contact tracers at one point, and so clearly people have been added to positions to help address the pandemic. But now that there is a sense of backing off from maybe the intensity of all of the work that has happened up until this point, is there something that you can tell us, or is there anything more that you're looking to do with DOH staff now that they're kind of freed, so to speak, from this intense reporting? And one real quick follow-up on Matt Hollingshead's question. What do you do with the self-reporting data if we're not putting it online? Are you just sort of holding on to it for now? Keeping the data? Is anything happening with that? Thank you.
Well, let me do that one first, Matt, or Chris, I mean. And I just noticed Chris and Julia and a few others who've been here since I think the very beginning attending these press conferences. And so I always appreciate new people asking questions and veterans asking questions as well. So thanks for that. What I said was, I probably wasn't clear. We will be putting that data online. We're just not going to include it in the total case count because those cases don't meet the definition of a case per the CDC. They still require a laboratory test positive for that. Second, what are all the DOH workers going to do now that they won't occupy all their time manually putting together reports? Well, there'll be a brief celebration, I'm sure. We've had also some folks who have done a really good job automating a lot of these processes. At the beginning of the pandemic, the DOH had 3,800 authorized positions, and the vast majority of them were filled, over 90%. We're now down to about 3,050 employees. I don't have an exact number yet for this month, but somewhere just around 3,000 employees. And so most of those people are going to go back to their real jobs that they had, managing a lot of other really important parts of what the Department of Health does, our numerous programs, our efforts to combat substance use disorder, our other vaccinations that we track and encourage, particularly among kids, providing regular health care in our DOH offices and public health clinics for people who don't have access to any other source of health care in their communities. Regulating and making in-person visits, again, to hospitals, nursing homes, assisted living facilities to ensure they're meeting license requirements. We haven't talked about this much here, but we're moving the remaining 5,000 people that have been on the DD waiver wait list for many, many years, some as long as since 2008, moving them off the wait list into service. So this is going to be a big renewed time for DOH. There was a House Memorial passed in 2021 to do a task force on the future of public health. We're looking at that. We're looking at our structure. How do we better adapt and redeploy our resources in the Department of Health to really not just chip away at, but make a significant difference in the huge gaps in inequity, the inequities in healthcare. So I could talk about this for the next 45 minutes. I try not to go more than twice as long as the question. So probably I'm at my time limit, but I have asked on other cases, I've asked them to put a box for self-reported cases, and we'll add that to the weekly report as well. I think it is good to get that word out.
All right, we have a couple more people in the queue. We have Jared Ebenrich from KUNM, and after that, Juno Ogle. Jared, you should be able to unmute yourself and ask your question.
All right, just confirming that you can hear me.
I
can hear
can. Hi, Jared.
This is Jared Ebenrich with KUNM. Thank you for the time. As you mentioned, the conversion of staff to other duties, one curiosity is how is NMDOH preparing for implications of long COVID and the chronic health and disability that may imply depending on the ongoing science? And how are the metric changes that you've described today playing into that preparation, as well as the staff reallocations?
You mean the metric changes for long COVID, or just the metric changes in
Well,
general?
for tracking the disease, how does that help
Okay.
New Mexico Department of Health prepare for
Yeah.
inevitable cases of long COVID?
Yeah. Well, we see cases of long COVID now. This is one of those ones where they should get a non-scientist to answer this question, because I confess I'm far too much of a purist on this one. Delighted. I was so totally delighted when in actually 2020, $1.1 billion was allocated by NIH to study long COVID in order to do research on long COVID, in order to define the disease, to define what the markers for the disease are, to define what treatments we might have for the disease. And so at 10 to 20% of people with COVID, and with the total number of cases we've had in the state being over, or coming very close now to a quarter of our population, that could mean that 5% or 100,000 people in New Mexico. No, 5% would be, sorry, what would that be? It would be about 10,000 people who could be suffering from long COVID in our state going forward. And so it's a really important effort. Some good friends of mine are treating patients with long COVID. Most common, the problem is not just persistent symptoms past 30 days, but significant fatigue. People with chronic lung disease who got COVID, who now have end-stage lung disease. People with chronic heart disease who got COVID, who now are approaching end-stage heart disease. So it's complicated. It's an overlay on top of underlying conditions, but we're also seeing long COVID symptoms. Some particularly disturbing studies have come out on lung lesions in people long after they've had COVID, 40, 50% of people, heart lesions, brain lesions through the past couple of years. And so I think that in general, most of the work that DOH will do, we may do a little bit in our DOH clinics, but probably mostly through working with our delivery system to come up with a more common approach. And I think when treatments are identified, if they are made available through the federal government, then of course we'll be first in line with our hand raised, kind of asking for more because of our vulnerable population. I think on the metric side, I think it's really hard to ask people to report the number of long COVID cases they're treating when there's no definition for long COVID. But when we get to that point where the disease is defined, then there will be new, what are called ICD-10 codes. So when I see a patient, I deal with 5 or 6 problems, and I put down a code for each of those problems. It's a standardized national code. There will be a code. There are codes in there that don't exactly say long COVID, but protracted COVID infection. In some time in the not too distant future, at least through Medicaid, we'll be able to start counting those individuals. It'll be easier when there's an official definition. And then based on some work from prior legislation, also not this year, but previous years, we're working on an all payer claims database within DOH where all insurance companies would submit de-identified data, so we'll know who it was, but and then we'll be able to actually count quite accurately the number of cases in the state. But that requires a definition, setting up the systems to do it, et cetera. And so I would doubt we would see much actual counting done probably for 6 months at the earliest, based on the speed of what's happening with research. Thanks.
All
I
right.
would say one last thing though, Jody, if you feel like you might have symptoms of long COVID or you have a relative, I really urge you to urge them or yourself to get seen, get evaluated, talk with your nurse practitioner, physician's assistant, physician, other treating provider about what you can do. And we're constantly monitoring, but there just isn't, there are anecdotal reports that people get vaccinated do better and with long COVID, and then there are reports that people who get vaccinated do worse, and they're not sufficient numbers to have any idea what direction the science is pointing. But it's an important issue. It's going to affect more and more of your readers, viewers, subscribers and blog readers. And so we're on that one. Thank you.
All right, next we're going to go to Juno Ogle from the Roswell Daily Record, and after Juno, we'll go to Susan Montoya with the Associated Press. Juno, you should be able to unmute yourself and ask your question.
Okay, thank you. And thanks, Dr. Scrace, again for taking our questions again this week. Juno Ogle here with the Roswell Daily Record.
Hi again, Juno. Good to see you again.
You mentioned earlier that the department's working on a preparedness plan for the next surge, which you've mentioned in the past could be this summer. But is that plan also going to include how to prepare for the next pandemic of another virus that could come along in the future?
It's a really good question. I'm so glad you asked. And it's just the perfect question for the second anniversary of COVID. So thanks for bringing it up. So a lot of people don't know this. We talked a lot about it in, 2 years ago, basically. But DOH had prepared an emergency preparedness plan for a giant disaster. And that could have been a huge weather event, an earthquake. It could have been a pandemic. And we phrased it as influenza epidemic at the time. And there were very, very detailed plans. And so when we knew that the pandemic was coming, DOH people raised their hand. It was before I was over there, pulled out this report and said, we already have this. And it was actually really quite good. So some little known facts about that plan were it called for the immediate formation of a medical advisory team. And so that wasn't, my idea, it wasn't the governor's idea, wasn't Mike Richards' idea. It was what really smart people in 2018 and then before that, 2014 to put together for that plan. So we do have that plan. Part of the preparedness plan for the next wave is to get that all in place. And then after that, take that plan and go back to the 2018 plan, update it for 2022, put those new factors in, because for example, it didn't have a section on testing, and turned out testing was everyone's obsession and full-time job, for the first 6 months of the pandemic. So we want to build on the foundation we already had. It served us very, very well. I think New Mexico's very fast start out of the gate, getting organized, was due to that existence of that 2018 plan. And yes, we will update it. Also, I think if you follow national news, we still have governors 2 years later bemoaning their inability to connect the dots between their delivery systems. And, New Mexico has done an amazing, the people in our hospitals and leadership across the state have done an amazing job coming together. I know these people personally. They are fierce competitors, and they all talked this morning, many with tears in their eyes. And some of these are like men with tears in their eyes. So it's a big deal, right? We're talking about how the relationships they develop, the desire they want to have to continue this effort in new venues, in pandemic times, at non-pandemic times, working to improve care for diabetes or behavioral health or the like. So it was a really touching moment for me. I was one of the ones who got a little emotional about it too. It was so great to just see the response people had just immediately. And I think that's what got us our quick start under the leadership of the governor, who likes to move quickly and decisively, clearly we all benefited from her leadership in that as well.
We have one more person with their hand up. It's Susan Montoya from the
And I don't know if I can share a little known fact. Susan, can I share something that you and I have in common?
Go for it, Dr. Strace.
So I have a teenage son named Ashton, and his girlfriend Sienna lives like really close to Susan Montoya. Is that right, Susan?
Actually, to my parents, right next door. Mhm.
Oh, to your parents, next door to your parents. Okay. But I assume you go to visit there from time to time.
Yep, a few times a week. So yes,
Okay.
definitely. Well, Dr. Strace, I was going to follow up on Jared's question about tracking long COVID. You know, there's also some interest in tracking adverse reactions to vaccines. Is there anything the state health department is doing to track that or plans to do as we go forward?
Yeah, there is a national database, and it's like a 5-letter acronym, I think. And if somebody wants to throw it in the chat, that would be great. But it's a national database. Maybe Brianna can find the website and pop in the link, where people can self-report vaccine reactions. So they're not medical reports of vaccines, they're self-reports. And so, of course, the number of COVID, Julia already put it in, and it's VAERS, VAERS.hhs.gov. And so with all the other vaccines too, there's always about 4 times as many individual reports of vaccine reactions as there are medical reports. This is true with COVID as well. And so I think the CDC and the Health and Human Services Department and others really comb through that data and analyze it and the like. We can go in and get or request, I forget if we can go in or just request data from the database to report on New Mexico. We follow that. It seems like, and it's been a bit since we looked at this, but when we did look at it, maybe 6 months ago, there was a pretty parallel, the number of reactions in New Mexico, pretty similar to elsewhere. And just a reminder to those of you who may be getting your 4th shot because you're immunocompromised, or hopefully we'll hear news about timing of another booster if it's needed soon. People do get reactions to the boosters, and that's a good thing. We don't want people to have serious reactions, but that achiness, that fever, that overwhelming need to spend a half day in bed or a full day in bed, those are all good things. It means that your immune system is kicking back in, you're multiplying, producing antibodies to COVID that will protect you going forward. And so many people in the VAERS database for every vaccine, not just COVID, put in that achiness, low-grade fever, flu-like syndrome, things like that, really badly sore arm, like you get from a second shingles shot. But those are known and expected complications. As far as serious complications to the vaccine, our experience in New Mexico has been that they've been very, very minimal. Thanks. Jody, I know Julie has another question in the chat there.
Well, that's all of our first round questions. How much time do we have left, Dr. Strace?
Well, it's the 2-year anniversary. And so it turns out this is my day off, but it's like a lot of my days off. So I'm free. My wife and I are sneaking away on a little vacation here as soon as I'm done. And, but I'm willing to take a few more questions. I mean, this is important stuff, and this is a milestone for the state.
All right. Well, let's, Julia, if anybody else would like to raise their hand, we'll go to Julia Goldberg's question first, and then I'll take any other questions if you raise your hand in the order that they come in. Julia, you should be allowed to unmute yourself and ask your question.
Oh, okay. I just sent it in writing because I was under the impression Dr. Space was tired of hearing my voice, which is understandable.
Hey. I never said that, and it's not true.
I have just been reading that nationally there's some concern about equity access to the therapeutics. And I know you've mentioned several times that you hope that we would have a shortage of the therapeutics, but that's a little different than ensuring that they're being distributed equitably. So I was wondering if how the state is approaching that and tracking that.
Yeah, well, we've had a little journey on that, Julia, and it's been a learning experience for me. I was very, very radically committed, shall we say, to ensuring that those who had the highest morbidity and mortality of from COVID infections, including pregnant women, certain race and ethnic groups, had absolute priority. And I guess my attorney, we launched some grading scales when resources were really, really short to try to prevent just having supplies just immediately disappear the first day we received them. And but it turns out that there are legal requirements and we can't do that. So what we're doing instead of that is we have a system for deciding whether to use Vexilabid and or molnupiravir, and it was based on risk factors. Now it's simply if you have COVID symptoms, a positive test, one or more risk factors, you're eligible for the drugs. We met with Courtney Lovato, who's one of the DOH superstars as well. This morning, she tells us that federal supplies are starting to increase, and we believe that in early May, we will have Paxlovid in every pharmacy in New Mexico who wants to stock it. And we're also now starting a program and discussed today sort of an outreach to providers to actually have the med in the office for those offices that can dispense medications to patients coming in, which isn't which isn't every office, but it's a fair number. You know, we have an awful lot of hospital systems that have lots of primary care offices, and we think many of them will qualify. We know FQHCs will qualify. So I think that the equity issue is an issue, particularly when we have limited supply and with case counts going down, and we feel like we're going to make it to when the manufacturer starts literally flooding the market with Paxlovid, which will be our preferred drug. We're also seeing, somewhat of a slow uptake among providers. And I tried to prescribe it once. I did, but at that point, it wasn't in our electronic medical record. I had to call up the DOH pharmacist. She told me what to type, and I did. It worked out fine. But now it's appearing in pretty much all the larger medical records in the state where it can be selected. It is tricky for doctors because it's still under EUA. And so we have to have the patient authorized and their understanding that this is an experimental drug. It's under emergency use authorization. It's not fully approved by the FDA. So that's another one of those barriers to easy access, but we're going to be working on that with our providers. And we think this lull is kind of a great time to do some education for providers, even getting it into offices. And so I think supply should be able to overcome the initial equity issues. And I think you heard me mention, UNM takes care of a very high SVI population. Presbyterian does, our rural FQHCs, DOH offices. So we're planning on rolling it out across the state because the best thing would be easy access.
Thanks.
All right, I see two more hands up. And the first is Susan Montoya Bryan from the Associated Press, and Jared after that. Susan, you should be able to unmute yourself and ask your question.
Yes, thank you. Dr. Scrace, again, we're talking about kind of coming out of the woods here finally and sort of getting back to normal a little bit and the physical aspects of a lot of this. But talk to us about the mental health aspects, right? Because that is a huge deal here. People have had to deal with this for 2 years, and what can we expect going forward?
So that is like you guys are doing such a good job. These questions are great, and they're all things I've been in a discussion with other people about who know a lot more than I do in the past 24 hours. So this is just great. We knew at the very beginning of the pandemic, based on the earliest data from Wuhan, China, from Italy, from other places, to expect a 20% increase in behavioral health symptoms. I think I shared with this group months and months ago, last summer, the CDC came out, and in public health workers, there was a 53% incidence of people who said in the past 2 weeks, I've had symptoms, not just but symptoms of depression, anxiety, PTSD, and even suicidal ideation, thinking about ending one's life. And so that's particularly high in public health workers, but we're seeing about that 20% here in New Mexico as well. And one thing that we did not have going for us was, gosh, it's 9 years ago, 10 years, 8 or 9 years ago, there was sort of a giant change in behavioral health and kind of a dismantling of the system that occurred. And so when I arrived at my job on January 1st, 2019, the governor's first priority was rebuild behavioral health, get us back on track, get more access for people in New Mexico. And so I am going to talk about the year before COVID for a bit, Susan, just because it's so critical to what our ability to respond has been. But we did that. We settled the many lawsuits, we hired, there was a movie called The Shake Up, and it talked about that whole history. And I actually recommend the movie. It was painful to watch. It still is painful to watch what happened in the Human Services Department many years ago. But it really chronicles the loss of behavioral health services in the state. But under the leadership of Neil Bowen, our behavioral health services director in HSD, Bryce Pittenger, who leads up our behavioral health collaborative, we've done an amazing amount of rebuilding of the network. We settled the lawsuits, as I mentioned. We had a welcome back to Medicaid. We went out and recruited people again. We raised rates to pay people for behavioral health services. In the same period of time, Senator Hickey has introduced really important legislation on not having any more behavioral health copays. That was passed last year, signed by the governor as of 1/1 this year, and no more copays for behavioral health services. And so removing that barrier for non-Medicaid patients who don't have COVID, don't have copays anyway, that's important. I'm giving too long of an answer here, but I'll finish up. And then I think a couple other things that happened. Nicole Como, our Medicaid director, immediately petitioned CMS for a waiver to allow Medicaid to pay for telemedicine visits at the same rate that we pay for a visit if someone came to the office. I know that helped our practice. I did all telemedicine visits for most of the 2020 after March, because we didn't want our elderly people coming to the office. And there was a huge uptick in telemedicine as well. It looks like CMS may allow some of that to be permanent waivers. We're certainly campaigning for that. It actually turned out the therapists thought people did better getting therapy on a Zoom call than in person, that they were in a more comfortable surrounding where they felt more at ease at home, perhaps, and so that it even worked better. So I still think there will be a post-pandemic wave. I think after Omicron, we'll expect to see an uptick again. And I'm really pleased with a lot of the progress the state has made, governor making it a top priority for me, the work my team has done, some of the excellent work legislators have done on a variety of fronts in substance abuse, in just behavioral health copays in general, that I think will be game changers and really help New Mexico continue to provide services. There's always room to do better. We still need more providers. We still need better access, and we still need better outcome measures. And all of those things are things we're working on. But if you go to the HSD website, click on scorecard, go to goal 1 and click on behavioral health. There's a couple of behavioral health sections. You can see some of the things we're following as we're trying to improve care in the state. Last thing I will say, in addition to increasing the provider network by 65 to 75% in Medicaid, we're seeing more, almost 400,000 more behavioral health visits a year in 2021 than we saw in, for example, 2018. So tremendous growth that we're really proud of, but lots more work to do. And thanks for asking that question.
All right, we have one last hand up, and that's Jared. Jared, you should be able to unmute yourself and ask your question.
All right, just confirming that you can hear me.
We can hear you.
All right. Thank you so much. Jared Ebenreck again with KUNM. Towards the fact, it seems the current public health emergency order expires next Friday, the 18th. There seems to be an NMDOH-led town hall planned for Facebook and Instagram that day by two other individuals to acknowledge a 2-year anniversary. So that public health order is over then. I'm curious, given the new metrics, what metric would end up pointing towards the need for other non-pharmaceutical interventions like capacity limits, masks, recommendations, crisis standards? What metric ends up leading back there if we do, as you say, have another wave and the wave is significant?
Yeah, I think that's another great second anniversary question, Jared, and I appreciate you asking it. We had no, and the reason I appreciate you asking it is we had absolutely no idea when this started what the metrics really should be. And now we really know, and we've been following this for a year now, but we really have stayed focused on hospitalizations. And I think that in the future, that hospitalizations trigger will be the trigger that makes us relook at all the policies and procedures. You know, it starts with things like visitation policies in hospitals and limiting visitors. But if we saw ourselves being overwhelmed, I think the only scenario that I think, I shouldn't say that. There are many scenarios that potentially could do that. But the one that I worry the most about is if we, like Omicron, we get another variant, we have 7,000 cases, and Paxlovid and Molnupiravir are not effective in reducing hospitalizations. Then we would see skyrocketing hospitalizations. One last thing too, just to mention, and that is the public health emergency order will continue in New Mexico as long as the federal public health emergency order continues, because the people of New Mexico, just through a Medicaid and SNAP programs alone, food program and health insurance, state health insurance program, have received more than an extra $1 billion a year of benefits related to the pandemic. And so we are tied to that federal wagon and we'll want to maintain those benefits as long as we possibly can. And so the plan would be to continue the public health emergency part of it until the federal order ended to ensure that New Mexicans continue to have those benefits. And now SNAP benefits are winding down now. We cannot renew those waivers anymore. Medicaid benefits will be winding down starting in August. Believe me, we'll be giving you a lot more information before that time comes, because the more New Mexicans can have their information up to date and available online, and we have their right address. You know, we still get 7%, 10% of the letters we send out to people because we still have to send letters for federal law get returned. And so those are people who could lose Medicaid benefits if we don't have their right addresses. But you'll be hearing a lot more. We're doing very, very intensive planning at HSD about this right now. And actually, I think the challenge HSD is facing with the unwinding of the pandemic, it might not be as much as DOH has faced with managing the pandemic, but it may well come close, as we have 1,057,175 New Mexicans who are facing a change in the benefits they're getting from the state. So thanks for that question. And is that it, Jody?
Well, we have one last hand, and then I really need to just cut this off. We have Austin Fisher, and that will be our last.
Okay.
So Austin, you should be able to unmute yourself and ask your question, and let's wrap it up there.
Thank you so much, Jody. I just wanted to follow up very briefly on Jared's last question. So given that the metric looking forward will be hospitalizations, I just want to bring into this, I mean, hospitalizations are a lagging indicator. It takes time for a person to contract the virus and then develop serious enough symptoms that they go to the hospital. So wouldn't case counts be an early leading indicator of needing to allocate healthcare resources?
It could, Austin. I mean, I think that's a legitimate point, especially based on the fact that it has up to this point. But remember, even with Omicron, while we had monoclonal antibodies, well, actually, we didn't have very much monoclonal antibody with Omicron, because immediately after the surge started, we learned that we could no longer use Regeneron and BAM, Eddie monoclonal antibodies to effectively work against Omicron. So 3/4 of our treatment arm was stripped away. But I think as long as we have effective treatment, we can weather what's now about an 8-day delay between cases and hospitalizations. Obviously, if cases start going up in a slope like we've seen with Omicron, hospitals will immediately reconvene. Actually, they're going to continue to meet every week anyway, because they like hanging out with each other so much now, and start doing the self-scoring that will follow. So we'll be watching that very closely as time comes on. The other thing that happens that would be informative is oftentimes we see these waves elsewhere in the world with Delta. I was talking with Christine Ross this morning. She mentioned that was the low point of the pandemic for her, is seeing what was happening with Delta in India, the rapid spread, the higher spread rate, the higher hospitalization rate. So we often know, like we even did before March 11th, 2020, what's coming. So we'll be fully prepared. I think, though, that what we've learned in 2 years is that hospitalizations are a constrained resource. But yes, absolutely, case counts are certainly a leading indicator in that regard. And we're still posting them and we'll still follow them. Thanks. Okay, Jody. Well, I just really want to thank everyone, really all the folks who watch this on Facebook. I want to thank our media partners who really ask great questions and keep us sharp and come up with new ways for us to think about things. I really enjoyed the partnership. Frankly, the partnership we've developed with all of you has been, for me, one of the high points of the pandemic. Believe it or not, I've never did a press conference before the pandemic started. And so it's been a learning experience for me. And I just appreciate the way you all keep reading, keep bringing new information, keep asking hard questions, keep making us think, and often think differently in ways that lead us to new solutions. So I wanted to give a big shout out. And tomorrow in my journal, and when I answer that question, what am I thankful for? I'm going to say all of our media partners who've worked so hard with us to keep people in New Mexico informed with the information and resources they need to make smart decisions about how to conduct their own lives, their families, their communities, their schools, their counties, their state. So thank you for that. And hopefully this will be the last press conference we have to have. It's another year anniversary. Hopefully this 3 months from now will look like the end of that influenza pandemic of 2019 without a big wave. But if there is one, we'll be ready. And I know you all will be as well. So thank you and have a wonderful day.
Thank you. I'd like Brianna to share her screen and we'll end with our quick little video.